Well, welcome back. My name is Richard Wexler. I'm the Chief Medical Officer at the Informed Medical Decisions Foundation, and it's my true pleasure to work with my colleagues up here to facilitate this discussion, shared decision-making in the real world, successes and challenges. And before I get too into this, I'd like to ask my partner in crime at the foundation, Meg Bowen, to please stand up. Recognize the work that Meg has done. Thank you, Meg. Meg and I have stood shoulder to shoulder and head to head as we've noodled our way through this over the last 4 years with wonderful learning partners about how to make this happen in the real world. And I just wanted to recognize her. And then there are others in the room who have worked in implementing shared decision-making in their organization. Some of them you've already met and others you'll meet tomorrow. But would you just stand up for a minute if you've done anything in implementation and shared decision-making? All right. Thank you. So these are the people who are making it happen. And I wanted to make sure that everybody recognizes the resource here and takes advantage of it by asking questions during this panel and then throughout the next day, and also sharing your own experience that bears on this. And this is a learning opportunity for all of us, and it's also a time for us to ask you to add your efforts to ours, as Michael has expressed about how to make the good work that's been done so far spread further and get deeper and be sustainable. And while financial incentives may be part of the picture, they're an important part of it, and there'll be a number of other incentives that we're going to identify, I think, to help us drive this forward. So with that, I would like just to take a moment to recognize how fundamental this change is. It is about culture change. We've heard about that. And it's about behavior change, and we know how hard that is. And it's about franchise systems and departments in medicine and the healthcare system and re-engineering rather than new construction. So that's why we need the help of everybody that's in this room and the help of all the people that are up here today. Let me tell you just a bit about how we'll run the format for this session. So we are trying something new. We've done lots of presentations as a group and individually about implementing shared decision-making, but we decided that we wanted to make this stick. So we've asked each of the presenters on the panelists to tell a story about the implementation that would somehow crystallize a challenge or a barrier, and then the solutions that they came with, and then sort of an epilogue to look back and see how that's worked out. And so everybody is going to, in turn, get up and tell the story, which would be one chapter in a long book, I'm sure. And after each presentation, we welcome questions about the content of that particular presentation. And after all of the stories have been told, we should have about 40 or 45 minutes for a group discussion, where we hope everybody will really participate and talk about their experiences, ask questions, and then what system changes we may make to add some heat to this effort, I would say. And I'm going to take the opportunity before we start with the stories to tell a little bit, share some information that I think will be helpful in setting context. So we're talking about the shared decision-making in the real world, and we wanted to develop a demonstration site program in order to figure out how to do this. And this is just a picture of the different sites that we've been working with, and the objective to show that shared decision-making and the use of patient decision aids can effectively and efficiently become part of day-to-day care. So we all came together. The planning for this began about 5 years ago, and we put out an RFI, and we were fortunate enough to use a number of different communication channels that would get organizations with appropriate cultures that had done significant quality improvement activities and try to bring shared decision-making into the focus of quality improvement. And we wanted to recognize that we were learning together how to do this. So we formed a learning collaborative, and we've been meeting monthly now for about 4 years. So we continue to learn about this, and I think we're all excited about trying to get the lift that if we could do this with better aligned incentives, that we would all enjoy the fruits of our labors even more fully. Those of you who have done implementation, you know it's close to the action. It's where the rubber meets the road, right? And it's going from theory into practice. And anybody who does it gets some bumps and bruises along the way. So these are the people who have done that, and the people in the room, they've done it. Here's what they used to look like. And we've heard about culture eating strategy for lunch, right? So they were lunch, at least in some of the organizations. But they've come through to tell the story, and we're going to hear about that in a minute. I wanted to suggest, and Bruce and others made note, that we have to not only create the will to do this, but we have to create the roadmap and practical tools to translate the theory into practice. So I wanted just to give you this sort of framework to consider as we think about implementation. And it may help with the stories, putting them into context. So the first part, we know engaging providers and staff in this effort. We talk a lot about patient engagement. We're switching this, so this is about provider and staff engagement and leadership engagement. And it'll be easier in some situations than others, of course. But how do we do that? And then once the whole team is engaged, who are we targeting to involve in a shared decision-making experience? And how are we going to identify them? We know that we can't rely upon provider or anybody's memory in order to bring this up, or we'll have low penetration. So we have to marshal technology, and we're not that good at that yet. But we've made some progress with that. And then there's if we're going to be using decision aids, there's a distribution of the decision aids so it gets to the patients at the right time. And then there's an engagement process. How do we encourage their viewing? What is in it for them? Why is this information being shared? If you don't explain that, we found that patients often think this is information from pharma trying to get me to buy something or to do something. And so there is a real need, and it can be done in 30 seconds, about encouraging the use of the decision aid, no matter what form. And then providing decision support, and that could be done by any number of people on the healthcare team. And that could be support around understanding the content of the information, understanding how to interpret it through the lens of what's important to you, given your values and circumstances, or how to put your decision into action. That decision support could be done if it's done in someone on the healthcare team. You may actually make the decision there and then execute, or it may be getting your questions ready, preparing for a visit where that decision will be made. Measuring impact. We think of that as something critically important, and not only for the quality improvement projects that we do that, but to engage in healthy competition, to give feedback around an individual experience, as Dale and others at Dartmouth have done in the Feed Forward reports, but measurement. And if we're going to align incentives and attach some sort of rewards to this, we need to have a measurement strategy, and we'll be hearing more about that shortly. And then providing feedback, so whether it's feedback to the individual clinician, to the patient, or about the program in general. So this is a general sort of paradigm that we have used, and it generally fits in terms of objectives to reach. And I want to talk about this one a bit more, because I think this is one of the objectives that is most challenging, engaging providers and staff. And I go back to basic motivational interviewing, where the motivation to do something is driven by the feeling that it is important and the feeling that I am confident that I can do this. And if either of those is lacking, we're not going to have the motivation. Now, the importance piece could be because it's a cultural imperative. This is part of the expected behavior. These are the norms, and we see this modeled in our organization, and if we don't see it in you, then you're not a good fit for the organization. And that may be driven by patient push for this. It's important to my patients, they're asking. And for many physicians, it is important for them to do this, to do shared decision-making. But it pales in comparison to a number of other things that are on the plate. We were talking earlier about how crowded that plate is of things to do. And from an ethical perspective, in a certain way, this is honoring the autonomy of the patient. But many other things crowd the plate that are related more to beneficence or doing for patients. And we've created that plate. We have filled that plate with pay-for-performance incentives that are quite filling, if you will, for the provider. So there's a lot to do about importance, and we're hoping that through better incentives and culture change, we're going to be able to increase the level of importance so it can compete with the many other good things that there are to do. And then the confidence to do it. Now, we need to make this accessible to clinicians of all sorts. And it's lived in a fairly academic world, and it's got its own academic jargon to it. But through training and embedded tools in the workplace and embedded into workflows, I think, and leveraging technology, we can build the confidence to do it. And there's work to be done here. And I sometimes remember that the personal and social history was an important part of any complete history and physical exam. And I wonder, where has that gone? But in a certain way, eliciting patient preferences, it's understanding the patient and their life and what's important to them. So in a certain way, that part is accessible if we think about this is the personal and social history relative to a particular decision. And it strikes me, all the discussion that we've had about not building the system with the patient in mind and now trying to build a bridge and invite them in, and we believe that the invitation is important, is such a, we've gone about it in the wrong way, and now we're trying to correct that. And I've seen these posters now around Boston put out by some of the health systems. You are a human being. So I'm thinking this is an advertising campaign, and if I was on the end of that, didn't you recognize that earlier? Well, the fact was no. So here we are. So we have to build the motivation and the confidence, and if we can do that, I think that will go a long way. The importance and the confidence to build the motivation. You've seen these, except for those of you who just arrived this afternoon. Jack Fowler showed them this morning. There's a couple of slides, but I want to use them as an illustration about how important it is to patients, again, to emphasize the point, and also to thank our colleagues who were able to capture this data and send it to us so that we can give you some information and that we can harness this together to promote systematic change. So this is role preference, and this is just one more example of that patients want to be involved. And in that level of involvement, as Jack said, it's not to be the technical expert to digest the information, but if we say, we can make a better decision together because it's important for me to know what's important to you. And it doesn't really matter if I, the physician or the clinician, makes the first offer about what might be a reasonable decision, but I might say, I'm not ready to make that without learning a little bit more about you, so please tell me something first, and then I'll be happy to make a recommendation. That's a good way to start a negotiation as well. But clearly patients want to be involved, and this is the other slide that Jack showed across demographic groups, and the question was, how important is it that providers give decision aids like this to you as a patient? And we developed this question pretty much as a marketing question for the program so we could build support for the clinicians to say what they're doing is important as part of the motivation. Okay, that's me. I'm going to stop with that, and I'm going to move now to some introductions. So these are our courageous change agents on the left. First here is Dr. Neil Corson, and forgive me, I'm going to read this. Neil is a family physician and geriatrician with 20 years of experience in practice. He graduated from the master's program at what's now TDI, or the Dartmouth Institute, in 2002. He leads a number of quality improvement programs at Maine Health, an integrated delivery system in southern and central Maine. Dr. Corson was first exposed to shared decision-making as a practicing physician when his office participated as a site in the prostate port study. Michael, everything keeps coming back to prostate. I just keep noticing. In the 1990s. He serves as a medical advisor to the shared decision-making program at Maine Health, partially funded by a grant from the Informed Medical Decisions Foundation. Next, we have Dr. Larry Morrissey. Larry is a pediatrician with the Stillwater Medical Group in Stillwater, Minnesota. Larry serves as the chair of the Minnesota Shared Decision-Making Collaborative. He's been working to support and improve the patient experience through clinical implementation projects, research, and community engagement projects since 2003. The theme here is that people have been working at this for a while, I think. His passion is to work with patients to make care more patient-centered and of the highest quality possible. Larry states, "Working as a team, we can find the best solutions for each person so that they can understand their choices and the best available medical evidence and ensure that their preferences and values are respected." Next is Dr. Charles Brackett. Charlie's a general internist practicing at Dartmouth-Hitchcock Medical Center and is an assistant professor at the Geisel School of Medicine at Dartmouth. He received his MD from Yale University and MPH from Boston University. In addition to caring for patients and teaching, he's been involved in several research and administrative projects involving the redesign of primary care practice to promote patients' behavior change, self-management for chronic disease, education, and informed decision-making. For over 7 years, he's been involved in implementing several different strategies to enable shared decision-making in primary care through decision aid distribution, clinician education, and using patient-entered data-fed reports to clinicians at the time of consultation. Next is Dr. Grace Lin. Grace is an assistant professor in the Division of General Internal Medicine and the Philip R. Lee Institute for Health Policy Studies at the University of California, San Francisco. Grace obtained her medical degree from the University of Michigan, and after an internal medicine residency and chief residency at Washington University in St. Louis, Grace completed her clinical research fellowship at the University of California, San Francisco. Her research focuses on helping physicians and patients make high-quality decisions that are both evidence-based and reflective of patient preferences. Current projects include implementing decision aids into primary care practice, including the Palo Alto Medical Foundation Research Institute, assessing appropriate utilization of cardiac procedures, particularly important topic now, and developing metrics to assess decision quality. Next down the line is Dr. Carmen Lewis, a practicing general internist and a health communication researcher with expertise in cancer screening and prevention and medical decision-making. She's been working with the Informed Medical Decisions Foundation for a number of years to implement decision aids in clinical practice, most of that work at UNC and soon to be in Colorado. And last but not least, Dr. Lee Simmons is a physician at Mass General Hospital. Her clinical practice is with the Internal Medical Associates at Mass General Hospital. Her research interests include patient engagement in care and shared decision-making. Dr. Simmons is on the staff at the John D. Stokel Center for Primary Care Innovation, where she studies the use of decision aids to help patients and clinicians in the shared decision-making process. In addition to her clinical and research interests, Dr. Simmons serves as a medical student educator and directs the internal medicine clerkship for Harvard medical students at Massachusetts General Hospital. So you see, we have a well-qualified group, academically and practically, who have been working at this for quite a number of years, and now's a chance to try this new form of presentation that is telling their stories about implementation. And we'll start with Neil. Thank you. I got one last slide. I'm sorry, Neil, they warmed me up with this. I don't know how that happened. And this doesn't seem to have come out quite right, but it should have been bigger. But picture this. The patient is talking to the doctor, and he says, "Doctor, I want to choose how I'm treated." The doctor says, "You're not just ill, you're deluded." And then here's where we're trying to get to, and the BMJ has been a great outlet for this. Advancing shared decision-making and embracing the patient partnership. And I'll let you decide who's the patient and who's the provider in that. And this is sort of the journey that we're on. And I think I would like to say that through the efforts of the panel up here and many others, we're quite a ways from the delusional representation there, but we're not across the goal line yet. And what we need is your help in getting us across the goal line. So thank you for that. All right. That one I didn't know. This is, okay, thanks.
Thank you, Richard. So the focus of my stories, I have several of them for you, is about something we were talking about earlier, which is who are we going to have to help the patient to make sure they understand the information about their options and think it through in terms of their preferences, so that anybody and everybody can participate in shared decision-making. So I want to start with a personal story. I've been married now for over 30 years. My wife has been very supportive of my career, so supportive, in fact, that over the past 10 years, she has had 3 preference-sensitive surgeries to really help me have the experience of what it's like to go through elective surgery in the healthcare system, and I'm very appreciative of that. Her most recent surgery was that she had spinal surgery just over 2 months ago. She is a nurse who has worked for about the last 20 years in fitness. Most recently, she's been teaching Pilates. She has, for the physicians and other providers in the audience, she had an unstable spondylolisthesis, which means in lay terms that in her low back, one of the vertebrae would slip on the other. This is how the neurosurgeon, he brought his own visual aid, does this. So that's what that means. And so you have a doctor and a nurse, and we were able to look at the literature. She did try some of the conservative approaches to treatment, but her pain was getting in the way of her ability to do her work, and we ultimately realized that the evidence would suggest that surgery was probably a good way to approach the problem that she had. So we were able to advocate for that. She had surgery, as I said, about 2 months ago. She had wonderful results, so this seemed to be a good decision in terms of the outcome, such that she was able to open her new Pilates studio just a couple weeks ago. So it's a successful story. The point, I think, of that story is that for a lot of my colleagues, as I've talked to them about shared decision-making, their feeling is that only people like doctors and nurses are really able to participate. And I know you heard a lot this morning about that sort of attitude, that many patients just don't have the capacity to do this. So I'm going to tell you just a little bit about where I work. Maine Health is an integrated system. Our target area, the area that we take care of, is the lower third to half of the state of Maine. Most of the people in Maine live there. There's not many people. There's a lot of trees up here. And we are a group of hospitals and then the medical system around those hospitals. Maine Health has actually been a partner for the foundation since we began in 1999. We, as part of our health system, have had patient education centers, which we call learning resource centers. There is a vice president, one of the leaders of our system, comes from a community health, patient engagement, patient education background, and she felt it was very important to put community health into the system from the beginning. Part of what our patient education centers have done is to develop focus groups for the foundation to help with the development of some of the decision aids. And in return, we have always had access to decision aids. So I think there's 5 learning resource centers now. There are copies of all the foundation decision aids, which mostly sat on the shelves. They were sporadically and randomly used. And so the opportunity to join the demonstration network was an opportunity for us to move from shared decision-making happening sporadically to shared decision-making becoming a standard of care and a routine part of the way we provide care for certain conditions. As we started working on our implementation, realized that it would be important to bring the stakeholders from around the system who might have interest in what we're doing and influence over our success together regularly as an advisory group. We had a number of patients as part of that group, as well as providers and administrators, some of whom were actively working on shared decision-making, others were not. And after about 3 years of our demonstration work, we decided together to write a white paper to summarize what we had learned and what we saw as the key elements of shared decision-making going forward. We developed a number of guiding principles. I think we ended up with about 10 of them. One of them is written here. And one of our guiding principles is that patients will engage in shared decision-making to the extent that each patient desires. So we want this to be available to everyone and anyone to be as involved in their decision-making as they would like to be. So I'm going to pause from that for just a moment to tell a second story, and that's a story of what I would say is the shining star in our system at this point that has actually made that happen. This is not primary care yet. We're still working on that. But in our prostate cancer center, they have made shared decision-making for men with early-stage prostate cancer. There's the prostate again, Mike. It always comes back. A standard part of care. This happened because a physician came along, a urologist, who was very motivated to make this happen. And one of the first things he did was he advocated for a resource. That resource is a nurse. They refer to her as a navigator. Her job, when a man is diagnosed with early-stage prostate cancer and presents for care in the prostate cancer center, is to facilitate a process by which that man and his family receive information about their options, so they receive a decision aid. They also have meetings with the urologist, the radiation oncologist, so that they can talk face-to-face about options and pros and cons. The evidence, I think, that this is a well-developed, balanced, unbiased approach, I think there's a couple of things. One is that best estimate right now is about 80% of men with early-stage prostate cancer fully participate in this process. So they've made it accessible to everybody. Second is that active surveillance, their term for not treating early-stage prostate cancer, but monitoring and working with the man to identify if something seems to be happening that might make them rethink their decision. Before this process started, 1 in 100 men were choosing to not be treated for their early-stage prostate cancer. Based on their best review of last year's data, which will be finalized next month, it is now 1 in 5 men who are choosing not to be treated and are involved in this active surveillance process. When I asked Jennifer, the navigator, what she thinks, or what are the key things that have made this a program that most men take part in, the story she told me was about as she was first starting to work as a navigator, which is about 2008, 2009, men who were told that one of their options was to not treat, it was not something they could even imagine, that they had cancer and they couldn't quite get their heads around the possibility that they were just going to live with that cancer. And she's seen, because of the success of the program, because there's now a strong prostate cancer support group across the state, so that men have been hearing from other men about this option, it has become clearly, in 1 in 5, a very acceptable option. So let me talk about how we've tried to incorporate decision support coaching at the primary care level as part of our work on the demonstration grant. We have some very forward-thinking administrators in our health system, and one of the investments that they started more than 10 years ago was to provide nurse care managers for the primary care practices across the system. The nurse care manager, they came from a variety of nursing backgrounds. Their work initially was with patients with chronic illnesses, starting with diabetes and heart disease, asthma, the ones that you might expect, depression now. And their job is to engage the patient in the self-management, in understanding their illness, provide information, and be a link between the primary care practice and the patient. We have had about 25 to 30 care managers. When the system was smaller 10 years ago, we've easily doubled in size in the last 10 years. So those 25 care managers were probably serving 40 to 50 primary care practices. Many of them were very well embedded as members of the team. They were in one practice all the time, or most of the time. People knew them. They had lots of interaction. As care management has been seen to be an important part of care for more aspects of care, as we've added to their plate and as we've grown the system, this several $1 million a year investment in care managers no longer goes as far as it used to. So that now many of the care managers are only virtually, if at all, connected to some of the primary care practices. They also, just as everybody else in primary care would say, have too much to do. Our initial sense of decision support coaching was we wanted to put it in the practice as close to the primary care practice as possible. We know from having done patient focus groups that patients' trust is in their primary care provider and practice. So we wanted the care managers to take on shared decision making. The problem was that they didn't have the capacity, and while we tried it for a while in the first year of our demonstration grant, it wasn't happening, and we had to look for another option. The option we had, because of the support of our patient education centers, was that we had a number of health educators who happened in some cases to be in the same building as primary care practices. So we turned to the health educators. They were trained. Kate Clay from Dartmouth does a lot of training of coaches to help with shared decision making. We brought Kate and had them train our health educators. They did a great job. The problem is, for our system, and you remember the map, we cover a large geographic area. We have lots of small town, rural kinds of places as part of our system. There's only 4 health educators, and they're all right around Portland. So we could not, and that's not going to change. In these days of budget cutting, we're not getting more health educators. So that while that looked like a very successful model, the problem is it's not a scalable model in our system. We are now working with the High Value Healthcare Collaborative. That's a group of health systems around the country that are sharing best practices in hopes of accelerating the process of improving care and improving, I'll use the word value. I know it's not a great one, but it's in the name, so we have to use it. And one of the first things, I've been involved for about a year now with our work on high value, is a Center for Medicare and Medicaid Innovation grant that is about patient engagement and shared decision-making. It's providing some resources those resources are allowing us to bring in some additional health coaches. And I'm sort of retrenching with this in that we need a well-distributed resource that has the right level of clinical expertise to do decision support coaching. So we're going to try again. As we're beginning to change the payment model, we think we might be able to afford to do this in primary care in a way that in the fee-for-service model was more problematic. And we're going back to the idea that this should be a nurse care manager job, and that's what we're going to be trying. We have a couple years with this CMMI grant to work on it, and I'm sure there will be more stories as we go. So thank you.
Hi, everybody. I'm Larry, guy from Stillwater. So that's a picture of Stillwater. It's a little bit of history for you, just so you have a sense of it, 'cause it's kind of important to the story. So back in the 1850s, there were two towns in Minnesota. There was St. Paul and Stillwater. They're about 25 miles apart from each other. St. Paul got the capital. Stillwater got the jail. You can decide who got the better deal. But it's important because Stillwater has a really strong sense of community. And when I moved there from Chicago in 1997 or 1996, that was one of the first things I really sensed is this town is independent, separate. It's not a suburb because we were here first. And why that's important is the community had, at the time that I started there, a physician-owned medical group and a community-boarded hospital. And they were sort of the classic versions of those institutions that you can imagine in your mind. The physician-owned medical group was as autonomy-oriented as they could be, 40 people practicing alone together in the same building. And the hospital was this kind of classic community hospital that sort of plugged along and tried to provide the services that they need. But the people in the community weren't happy with how it was going, because they wanted more, and we saw that because people left town for care when it was something important. And so you saw people leaving for other institutions for conditions like breast cancer when we were trying to offer those services. And the institutions got together and said, you know, we need to grow, and in order to be successful and really meet our goal of meeting what the patients are asking for from us, we've got to work together on this. And so the two institutions integrated, and that happened in 2004. And in the process of those discussions, there was a lot of clarification of values. You know, every organization can go, it's been 2 years since we redefined our values. And I think as we were doing that discussion, the idea that meeting the community's need of being patient-centered was really the thing that could allow us to stand out. That's something that people identified with personally. And as a leader in the organization, at that point I was the medical director of quality improvement, as a leader it was something that I could call out to people and they saw it as being an important part of their job. So I think that word is actually kind of important because words have meaning to people and we define them differently, and we often need to make sure we're using the same word in the same way. But this construct allowed the physicians and the medical or the business leadership to kind of be on the same page of where do we want to go as an organization, who do we want to be. And so here I am, the quality improvement director in this group, failing more often than I succeed, trying to get family practice docs to make their diabetes numbers better, and who wants to listen to Larry? He's just a pediatrician, and he's really an idiot. And what are you thinking? And I got to figure out a way to get people to be engaged. And one of the health plans, had these requirements of us to do quality improvement projects. And I wanted to do something that made my job more fun. And so I talked them into letting me do a project on shared decision making as part of our quality improvement requirement for the year. And so here I am with this project, and now I have to figure out kind of what to do. And I decided, not because of this meeting being focused around prostate cancer, but rather just because it was convenient that we only have one urologist. So there's Tom. Tom's our one urologist. So I had an N of 1. If I could get buy-in from Tom, I got 100% buy-in, right? So I go to Tom, and Tom was actually new. And he's thinking, well, I got to do what they tell me because I'm the new guy. And Larry's nuts, but I'll try. And I said, can we try doing this shared decision-making thing? And we made a plan. And the plan, actually, Neil summarized our plan really well because it's exactly what he described. And, in fact, we talked to the people at Dartmouth, and it was exactly what they were doing. So it seemed like a pretty good plan. And it can't just be me talking here, so I'm going to let Tom tell you how he thought it went. Oh, wait. Back. I think I got to do this. This might be a problem. Yeah, I got to hover on. I just got to figure out how to do it. Yep. Here we go. Play.
When he brought this out to me, he said, I want you to just look at this. It's not going to give you away. Just see what you think. And that was the perfect thing to say because I looked at it and I was open for it. And the more I looked at it, I thought, you know what, we can at least try this. I tried it. And from the very first patient I tried this on, I said, wow, this was a legitimate process. The patient was more comfortable. I was getting through to them. And I saw the value of it. So I emailed Larry back and said, Larry, looks like it's the real thing. I'll keep doing this. Let's keep moving this forward.
So, if you were writing down your notes, kind of what do you need to be successful trying to make this a reality in practice, two crazy guys who are willing to try things that they might not necessarily think would work, that would be a helpful component. Second helpful component, and these are, I have to apologize, I was trying to video edit, and I'm not really good at that because I'm splicing these out of a 10-minute long video that we have. But is that it's got to have value for both parties. And I think one of the things that we found as we implemented this project is not only were the providers feeling motivated, the patients were. So I'm going to show you some video from a patient named Kathy. I think the testimonial in and of itself is that Kathy was willing to come into the clinic without being paid or anything else and let us sit and make a video of her that I could take around the country and show other people. And in particular, this wasn't scripted. The person who made this video asked her open-ended questions about her experience. So why that's, I think, important is when you listen to what she's saying, I didn't ask her to say this. These are her own words about her own experience in these next two clips. And I think it shows that we're going in the right direction.
It's really kind of changed the dynamics of your relationship with your physician because it allows you the opportunity to have a dialogue and you feel better informed to do so.
And then the next one, I couldn't make them go together, so I had to do them separate. Come here, little arrow.
The shared decision-making process does make me feel more vested, and I believe that you have to be proactive in your medical treatment, and I think it empowered me to do that.
So this is not a great picture of Tom, so I'm going to try to be away from the slide. So I really literally figured out how to make these like last Sunday night in my basement. I was like screaming, yeah, I did it. So now we have two groups of people who are both like feeling the love. And the great part about this is in terms of changing the culture is it set a fire. And you sometimes to change a culture you need the burning platform. And what people saw was that they heard about this experience and wanted to bring it other places and were asking for it. And so the organization would let Larry do his crazy stuff in other places. And it spread to breast cancer. It spread to depression. It spread to BPH treatment in primary care. And now we've started working on PSA testing in primary care. And it's kind of permeated And it was the experience of doing it that allowed that permeation. But you're never really sure with QI projects, are you there yet or not? And this next little clip is when I kind of knew we were there. Now, what happened was that we had 2 care coordinating nurses who were working on this, and they kind of backed each other up until one week, unbeknownst to me, the 2 of them were sort of not getting along with each other, so they weren't talking. And they both took vacation the same week. So now I have no nurse care coordinators and 2 prostate cancer patients who show up. And then they got to Tom. There it is. There was a moment where, for various reasons, a couple of patients didn't get shared decision making and ended up getting to Tom. And Tom made sure that they went back and got shared decision making. And for me, that was the moment at which the process went from being something that we add in to it was a defect when it didn't happen.
And from there, it's just kind of blossomed, and it's become a part of our culture.
So that's his own words. And that's kind of why I put that clip on there, because that sense that it's a part of our culture, it permeates. And when people see me walk down the hall, they go, "Hey, Larry, how's shared decision making doing?" But I think more importantly, people who interact with us as an organization think about shared decision making. And kind of the next stage of what happened is that this little hospital clinic thing, we ended up looking around our environment and decided that we really needed to be part of a larger ACO. And so we joined Health Partners, which is a large ACO in Minnesota. And when those negotiations and that integration was happening, the people from Health Partners very consistently came to us at the very highest levels of the organization and said, one of the things that's going to benefit us as an ACO is that we get you guys and we get shared decision making. And our opportunity to then take this work and start to bring it out to an even larger organization has presented itself. Now, I don't want to make it sound like everything's perfect in Lake Wobegon, because we're not all above average. And it certainly had lots of bumps in the road. And like I said, I fail more than I succeed. But we are slowly and persistently, passionately moving the work forward, getting it out into the larger organization and trying to make it happen more consistently. And we just have to believe that you can do it. And my take-home message to you guys is that if Larry can do this, you can do this.
Okay. So Dartmouth-Hitchcock Medical Center is an academic medical center in rural New Hampshire, in the middle of the trees here, where shared decision-making got its start with the ideas of Jack Winberg in the 1980s, and pioneering work integrating shared decision-making and the use of decision aids into clinical practice was done by Jim Weinstein in the Spine Center and Dale Vidal in the Comprehensive Breast Program in the 90s. And the nation's first Center for Shared Decision-Making was established in 1999. Here it is on the main mall, the main hallway in our medical center. The DHMC section of General Internal Medicine consists of about 40 staff physicians who practice primary care and teach residents and medical students. When we started our work in implementing shared decision-making in GIM in 2005, we initially focused on how to best distribute decision aids using the video decision aids you've heard about from the foundation. However, it quickly became clear that merely inserting the decision aids into the workflow was not enough. Our first distribution project involved the PSA decision aid. Despite guidelines recommending shared decision-making for prostate cancer screening, and despite Dartmouth's reputation for shared decision-making, we learned from questionnaires returned from our patients that some of our clinicians were recommending screening and others were recommending against screening, essentially deciding what made sense for them and then applying it to all their patients. Other physicians thought they were already practicing shared decision-making, but were really practicing substituted judgment, making individualized decisions for patients based on their own assumptions of what that patient wanted without actually asking the patient. There's ample evidence on how bad physicians are at guessing patient preferences. So we came to realize that although we were perhaps ahead of the curve, there was still some culture change that needed to happen to encourage shared patient-centered care and a more equal partnership in decision-making. Many were still socialized to various extents into the traditional roles of paternalistic physician and passive patient. It also became clear that practicing shared decision-making required knowledge and skills that many of us lacked and that haven't been taught in medical school and residency programs. We realized that we needed to augment decision aid distribution with clinician training and marketing to encourage this culture change. The most important steps to learn are those at the beginning of the shared decision-making process, recognizing that there is a decision to be made without a clear right answer, that we're in the gray zone, and explicitly inviting the patient to participate in that decision. There's also the skills of how to do clear risk communication. And an important skill is values clarification, because different patients will make different decisions based on the same facts and figures. Lastly, it's also important to be able to recognize and resolve decisional conflict. We found, as have others, that a workshop or a couple lunchtime talks won't lead to lasting change. There needs to be frequent inoculations of knowledge, cueing and reminder systems to prompt action, an easy and intuitive process for using and ordering decision aids, and feedback on performance and results. Culture change is a gradual process that should be expected to take years. Other barriers were recognized and addressed as we continued our work enabling and encouraging shared decision-making. We learned from focus groups that clinicians were uncomfortable using decision aids when they weren't familiar with the content that was contained within them. So we held some lunchtime talks, offered a free lunch for patients to come and attend screenings of the decision aids to be familiar with the format and content. And together with the foundation, we came up with a series of 1 to 2 page decision aid summaries, so physicians could quickly, in a couple minutes, find out what's inside the decision aid without having to watch 20 half-hour-long decision aids. Other attitudinal barriers to the use of decision aids proved to be misperceptions, as Jack Fowler mentioned earlier. Clinicians cited time as a barrier, yet our questionnaire responses showed that using decision aids was either time neutral or actually saved time. Clinicians also felt many patients wouldn't be interested in viewing decision aids or wouldn't be able to understand them. But results from patient questionnaires showed that almost universal enthusiasm for receiving decision aids, and that patients of different ages and educational levels were all able to benefit from their use. In our first few years, we tried 4 different ways of getting cancer screening decision aids to the appropriate patients. Comparing these methods led to 2 conclusions. 1, make it automatic. Build decision aid delivery into the workflow in a way that doesn't rely on individual initiative. And 2, deliver the decision aid before the visit when possible. Pre-visit delivery allows the patient to arrive at the visit more prepared to make a decision, leading to a richer discussion with the physician and allowing the decision to be implemented during the visit. Our initial automatic pre-visit method for PSA decision aid delivery consisted of 1 year of sending the decision aids to all men aged 50 to 75 prior to a preventive medicine visit. After a year of this, a more selective and efficient distribution method was needed. So we enhanced an existing online patient questionnaire to determine eligibility for screening, offer decision aids, deliver the decision aids in 2 formats, the choice of video or a quicker print version, assess the patient's knowledge, values, and certainty about the decision and which way they were leaning, and feeding this information forward to the physician in a report. So at the time of the visit, they could have a quick assessment of where the patient stood and have a head start on how to lead the conversation and arrive at a higher quality decision. Moving forward, we're pursuing automatically delivering decision aids to the appropriate patients pre-visit through the electronic medical records patient portal. In this example, a brief message about the shingles vaccine is sent to patients turning 60 years old with a link down here that brings you to the HealthWise decision aid online decision aid on the shingles vaccine. Dartmouth has an international reputation in implementing shared decision-making, but we have come to realize that outside of pockets of activity in general internal medicine, orthopedics, and the care of breast and cancer patients, many at Dartmouth, especially in our community practices, are still not truly familiar with the rationale for and the process of shared decision-making. Because of this, we have recently teamed up with DHMC's Communications Department to plan a comprehensive institution-wide marketing and training campaign. This will include updating internal and public websites, messages from leadership, outreach and training to all the clinical departments, reminder letters, and other messaging to patients to promote patient engagement and involvement in decisions. Our goal is to change the culture and expectations of both physicians and patients, and to make the resources readily available to make shared decision-making a routine part of clinical practice.
Good afternoon. I'm Grace Lynn, and I would like to spend the next few moments describing the challenges that we faced increasing patient engagement and shared decision-making within the confines, concentrating within the confines of our current reimbursement system at Palo Alto Medical Foundation, which is a multi-specialty group based in the San Francisco Bay Area of about 750 or so physicians, and serving a population of about 750,000 people, primarily in a fee-for-service basis. So we face some unique challenges, as you all do, as many fee-for-service enterprises do, in terms of integrating shared decision-making. Our work was done as part of a demonstration project funded by the foundation, led by myself and Dominic Frosch, when he was at the Palo Alto Medical Foundation Research Institute, and our colleagues at Palo Alto. So when we started this implementation project 4 years ago, our task was to find ways to integrate decision aids into routine care and primary care. So we met with our clinics and did the usual QI things of meeting, planning workflows, and setting up a distribution system. And we thought, great, this is going to be great. Everybody's enthusiastic. As we started the project, we started realizing that many of the patients actually weren't getting the decision aids. When we ran the numbers, we found that only about 10% of eligible patients were getting the decision aids. And so we wondered, well, why is that? Why, even though our physicians are really enthusiastic and they're telling us they're really enthusiastic, isn't this happening? So we went to our clinics and tried to find out what barriers there were to prevent physicians from routinely distributing decision aids. And this is what we heard. So let me start by putting up a diagram of what a typical primary care visit is like at PAMF and as many other places in the country, and some of you who are practicing might recognize this. So imagine the typical primary care visit for maybe a 70-year-old man with chronic medical disease. In a 15-minute visit, there are lots of agendas that are going on. The physician has an agenda wanting to do some chronic disease care. The patient is interested in his acute complaints. Somewhere in there, we need to do some preventive medicine as well. And then in the background, there are system elements, including the EMR and sort of clinic agenda that are overlying and putting pressure and burdens on the primary care physician to complete. So basically, a lot of these things are supposed to improve care. For example, reminders in the EMR to do colon cancer, talk to your patient about colon cancer screening. But in fact, they add burden to the physician, and they incentivize physicians to do only the things that they're measured on, of which shared decision-making currently isn't one of those things. So when we went to the physicians and said to them, well, in addition to all these things that you're already doing in this 15-minute visit, let's do some shared decision-making too. How do you think they reacted? Like this, right? Even on the outside, if they were saying, yes, this is the right thing to do, we believe in this, on the inside, they really weren't wanting to do this or ready to do this because they viewed it as an added burden to care. And it was just another task they had to do. And part of the reason that they thought that it was an added burden is, and you can probably guess this, it has to do with time and money, right? So we ran into this head first in one of the distribution models we piloted, which Christine Bechtel alluded to earlier. So what we did was we placed a screener at the front desk where patients were able to come and say if they were eligible for colon cancer screening, they're over 50 and they hadn't been screened, that they said, yes, I'm interested in getting a decision aid. And they checked a box, and a person at the front desk handed them a decision aid. And patients love this. The distribution in that clinic went up fivefold when we did this. About 2 or 3 weeks later, the physician leadership came to us and said, you know, we have to stop this. And we said, well, why? The patients love it. And they said, well, the doctors don't like getting the additional questions that these decision aids are producing. And in fact, what the physicians felt was that this was disrupting care and not adding, adding burdens to them, to the visit from their point of view. It wasn't adding any value to the visit. So it became clear that without the change to the visit model, it would be difficult for decision aid distribution to become part of routine care. So we talked about this with our physician champion and our steering committee about how else can we do this. And we came up with a shared medical appointment model. This has been implemented at PAMP for several years in many different topics. And it's based on the drop-in group medical appointment model where one physician and a nurse and a social worker meet with a group of patients who have a similar condition, and they do a group appointment. At PAMP, we decided to introduce this in the context of geriatrics so that we could cover the preventive medicine and geriatric assessment that often doesn't get done in primary care due to time constraints. So what we came up with was a series of 3 90-minute sessions called Mind, Body, and Soul, each focusing on screening for a high-risk, high-impact geriatric syndrome. And they're run by a geriatrician, Dr. Peter Chang, a nurse, and a social worker. And the first session covered memory problems and screened for memory concerns and dementia. The second one screened for falls and discussed fall prevention. And the third concentrated on depression. In the typical SMA, you can see here, there are 6 to 12 patients. And incorporated into this 90-minute session are personalized assessments of cognitive function, of physical function, and of mental health. And these are 3 different weekly sessions. The patients also view parts of the decision aids provided by the foundation, including one on growing older and staying well and one on advanced directives. And then they're also given other decision aids based on their chronic medical conditions as appropriate. And there's also group discussion and education addressing geriatric topics to help the patients engage in their care and give them an opportunity to discuss how to be more involved in their care. The nice thing about this model is that because there are personalized assessments and all of this is documented in the electronic medical record, all of these visits are billed as a 99213 visit, so the physician is reimbursed for his time seeing these patients. To date, more than 150 patients have participated, ages 61 to 90. People often, the bring their spouses and caregivers, so it's truly an integrated model. And the patient feedback has been very positive because they get greater education, greater support, and engagement in care than they're able to achieve in a typical 15-minute visit. Because after all, they're getting 90 minutes with both a physician, nurse, and also patients like them. From the physician side, the reaction has been very positive as well. It's viewed as a way to unburden the primary care visits. So some of the screening that's supposed to get done there can be done now in a different setting. And it's an opportunity to engage the patients in some shared decision-making and increase patient engagement without the time pressures of that 15-minute visit. So this has been one of our most successful ways of introducing decision aids and shared decision-making at PAMF. And other geriatricians in the system are now looking at setting up their own shared medical appointments. So I just like to leave you with the message, I think, that models of care like this that allow the physicians to feel like that they have time to practice shared decision-making and aren't disruptive to care really lead to greater satisfaction for them and a greater likelihood that shared decision-making gets integrated routinely into care. Thank you.
Hello, everyone. I'm Carmen Lewis, and I'm going to share with you, I think, one of the themes today has been the power of story. So I'm going to start out with a story and then go to our demonstration site information. About a couple of weeks ago, I was making a date with a friend who is a researcher and internist, and we needed to discuss some issues about research. And he told me we were trying to make a date back and forth when I could visit with him, and he said I needed to come pick him up. We were going to meet for lunch, and he had reported that he'd had a hip replacement in the time since I'd seen him. So I got in the car and went to see him on our day that we were supposed to have lunch, and he'd lost about 20 pounds and was standing there waiting for me out in front with a cane and looking quite frail. Over lunch, he told me the story about how all this happened, and he actually interviewed 3 different surgeons. He's actually split between the 2 institutions, so he had the opportunity of talk to 3 different surgeons about their complication rates, about their outcomes, and when he was done, he picked a surgeon and he had the surgery. And then when he went home, he said, I could not believe how unprepared I was to come home from a major surgery like this. So he had his wife on the internet looking for a lift to help him get out of bed so he could go to the bathroom. So I tell this story to say, despite the fact that he's in our business, he was ill prepared despite doing due diligence about the surgery. To know what it was going to be like when he came home from his hip replacement. So how do we do better than this? How do we provide information patients need when they need it? And I'm going to describe a little bit about how we did this at UNC. So first, before I go into detail about our program, I need to let you know about our culture. And we've talked today about how important culture is, and UNC is in the South, and by definition, that means that change is slow. We also have an issue that we're a state institution, and we care for a lot of people who have no insurance at all, so we've got that challenge. As well as at the time when we started this, we had a top-down leadership who, was not interested in us pitching ideas to them about shared decision-making at all without having some outcomes. So we knew we weren't on their radar at all. We needed to have some outcome data before we went up the ladder to the leadership at UNC. So we were left with engaging our practice on the local level. And we knew that once we had some results, we could go back up the ladder a little bit. So at the practice level, we're an academic institution, and we have over 100 providers, most of whom are trainees, working less than a half a day in clinic. So we had the challenge of getting physicians on board multiplied by multiple times, as you might imagine. We had a lot of challenges with communication and always have. Obviously, getting people on board for decision aid delivery and shared decision making was going to be challenging. One important thing that we had going for us was our division head was a local leader, and he put a lot of emphasis on this program and how important it was to our practice. So I think that was a key point for us. So the first thing we did is we tried to leverage all of the existing resources that we could find that were already going on. So we tried to synergize with these. We'd had a lot of success putting systems in place, and people have talked about chronic disease management and applying this decision support, and we tried to do that. And I think most people have these systems in place. Not everybody's applied to decision support delivery. But despite that, I think what was probably the most helpful was the core team that we had. We had the right people on the bus. We had the person that was in charge of our disease management programs, and he's an implementation genius, literally. We had our team members that were working on this project that were embedded within the practice itself, and they became just part of the practice, which I think was key. And we also had our programmer who at the time was able to pull data from the data warehouse and also push data to the electronic medical record. So having that team was key to us. So the end result was that we developed a patient health survey, and we were able to ask patients about symptoms, and we were able to ask them whether they were interested in getting decision support or not. We were able to deliver decision aids in the clinic. We were also able to mail them out. Physicians could request them as well. We had an electronic system so that they could do that. And also, we empowered our disease management staff so they could deliver decision aids on diabetes, chronic pain. And our dietitian was providing decision aids as well for weight loss surgery. So we basically used every avenue we could think of for delivery. We even developed a secure website. This was before UNC had a portal, so we did this on our own so that people could sign on and complete the patient health survey and then watch a decision aid before the visit. But that got us half the way there, and we had a way to deliver decision aids, but we didn't have a way to know if people were using them. So again, we leveraged our existing technologies. This is what we call our fancy reminder system, the visit planner. So this is what we were using for our chronic disease management program. And you can see here that we implemented a follow-up program for the nurses to ask about use and satisfaction with the decision aids. Wow, this thing's like possessed. All right, I'm not going to touch anything. Where was I? So we knew that we could get the information we needed to take back to the UNC healthcare system itself. The second thing we did is we tried to engage providers and staff, and other people have talked about this as well. We used the usual approaches with conferences and lunches and those kind of things. But I think there were two things that made the most difference. The first was that we showed a video like Larry showed to our staff, and the patients were describing how important decision aids were to them. This showed the value of the decision aids to the patients, and it also hit a core value of our practice, I think. So that was a major turning point for us. The other thing we did, which was not planned, but had a huge effect on the staff as well, was we worked with the journalism department to develop a social marketing campaign, and we've also kind of talked about that a little bit today. But as a part of this, we wanted to get photos of people in our practice so that the patients would recognize them as we had these posters plastered around our practice. So I asked for volunteers thinking we'd have 2 or 3 people show up, and it ended up, it was before clinic one morning, and we brought coffee and food. And it ended up that, almost everybody in the practice came, which was really exciting, and we had tons more people than we could use for the photo shoot. But what kind of happened was an impromptu party from this. And before we know it, so I think what happened was people saw, they had a good time, so when they would see, this was the result of the photo shoot and the social marketing campaign, the Healthy Partnership. And when they saw this around the practice, I think that this kind of motivated them, made them have a good feeling, like a vacation picture or something like that. All right, so although not everyone was on board with our project initially, we were able to rally the troops locally, and we had significant support over time. Somebody was asking about the adoption curve, and this is our physician request, the number over time of decision aids, and this is not part of our disease management program. These are just, happen spontaneously when doctors think, oh, I should do a decision aid. So you can kind of see that over time it's become adoption. I hope it's not heading back down, but we will see. Before I got on the plane, I was having to precept in the clinic, and I had one of the residents come and was checking out with me, and he was talking about this patient who was really obese and would benefit from bariatric surgery. And I had not met him before, because when people tell me that they're going to prescribe a decision aid, I just figure, they know that I'm the decision aid person, so they're telling me that. But I hadn't met him before, and he said, oh, and by the way, I'm going to give her a decision aid on the way out the door. And I thought, wow, maybe this is really catching on. So as far as for the UNC, as far as going back to the UNC healthcare system, we have some satisfaction data we can take them as well as part of this follow-up. And the future is looking brighter because we now have a new quality initiative, and where the patient engagement is going to be a high priority in this quality initiative. So we're looking forward to see what the future will bring. Thank you all.
So thank you. I'm going to share with you all some of the work that our shared decision-making program at Mass General has done, and I work with Karen Sabuka, who we'll hear from later on in the afternoon. And I'm going to tell the story of how we've worked to bring somewhere around 350 clinicians on board with prescribing decision aids for their patients and learning about shared decision-making skills, and also how we've invited patients to become a part of the decision aid ordering process and actively engaged in our program. So our clinicians in 17 primary care practices at Mass General have been able to order decision aids for about, since 2005, so several years. And they can do that through the electronic medical record. But for a long time, we saw that usage was highly variable. Some people prescribed a lot, and then some never used it, said they hadn't heard of it or they didn't use it frequently. And they said that the barriers were, they really didn't know about what the program contained, and they thought maybe the prescription program would be difficult to use, so they just kind of stayed away from it. And then the usual barriers about time and worrying about bringing up too many questions at the time of the visit. So we developed a training program for our clinicians and for our internal medicine residents, where really the key components were we actually asked them to watch a decision aid in entirety. We thought that we had heard, and we had surveyed our clinicians who used them. We heard that the ones who had actually watched a program in entirety really liked them and wanted to use them more. So we asked them, and as part of this program, we asked them to watch it in entirety. We then went over the ordering process, demonstrated it's actually quite simple to use, just a couple of clicks. We know that the fewer clicks, the better, so it's very simple. And then we actually gave some comparative data, how practices compared in ordering programs, and then actually down to the individual prescription level. And we found that our prescription rates of the programs really soared after that, and they stayed high after we initiated this program of clinician education. This picture here is from a recent session we did with our residents. It's kind of early in the morning. They're all watching the acute low back pain decision aid program, so they could learn about that and be more familiar with our program and learn also about maybe some tips on talking to patients about acute low back pain. So we initiated this program. We found that people prescribed more. New people who'd never prescribed before started using them. But we hadn't fixed this problem of uneven prescription rates. Even in the same high prescribing practice, there were still some doctors who never used the programs at all. So that meant that many of our patients were left without any access to decision aids if we were relying on a prescription model from doctors. So we decided to tap into our patients to see if they could tell us what they wanted and needed when at the right time for them. So we worked with one high prescribing practice who, among 8 staff doctors and 8 residents. In a 2-week period, they'd ordered, and this is a high prescribing practice, 3 of those 16 doctors had ordered 9 decision aids for their patients, okay? When we then put in a system in place where we actually had our medical assistants hand to patients an order form with our top 10 or 12 most popular programs, a brief description of the programs, we had them hand this in when they were checking the patients in, getting their vitals for any visit, urgent care visits or annual visits, and they took a look at it, and then they could order a program at the time of the visit. We found that the prescription rates went up from that 9 in the 2-week period before we did an intervention, up to 88 in the next 2 weeks when we did this simple intervention. And the programs they were ordering were different from the typical ones. We usually see that our doctors were ordering, is a PSA test right for you, colon cancer screening options, and advanced directives planning. Our patients ordered the insomnia program, depression, low back pain. Those were the most popular. Someone mentioned earlier about outstripping the supply. We actually quickly ran out of our own supply of decision aids in some of the programs, so we had to take those clipboards away for a little bit. And so we really felt like our patients had spoken really loudly and clearly that they had symptoms, they wanted information, and they were ready to place orders for these aids. This first implementation, I'll be honest, was not perfect. So the medical assistants thought this was interesting, but they actually said, "Oh, sorry, it didn't really work out so well." And I'm thinking, I thought this was really super. And I said, "What do you mean?" They said, "Well, like 9 out of 10 people said they didn't want a decision aid." And I thought that 10% wanting them was really great. 10% were ready for it. But it was interesting because they actually saw that as a lot of refusal. They didn't like that feeling when many people said, "No, not for me, I don't need it." And it didn't let people look at the programs before the visit, so we didn't have a great opportunity to close the loop. After they'd watched a program, they were getting actually at the time of the visit, and some people were scheduled to come back in a year or so in our primary care practice. So there wasn't that great built-in opportunity to close the loop. So we changed the program a little bit. And we actually, in that same practice, we now either mail or in some practices message patients through a portal before they come in for an annual visit. We chose that as a visit that's booked for a little longer time and gives some more time to maybe discuss some issues. And patients could then mail back an order form of what they wanted or send that back through an email. And then the medical assistant will still process the order. This is one of our medical assistants with one of our residents here, and they're happy to be involved in the prescription decision aid program. And we find that same pattern of patients wanting to address chronic symptomatic conditions like anxiety. We now have an anxiety program we offer. Depression, low back pain are still the highest on that list of patient-requested programs. And we've also found that the whole care team gets really involved and interested now, which has been great. This actually dovetails very nicely, I have to say, with some major practice improvement work we're doing. So we've actually given ourselves the mental space to do some of these activities. When we've cleared up some of the other inefficient processes, we were ready to take on shared decision making. But one of our medical assistants, Yolanda, who was thrilled to know she was going to be included in this presentation today, said to me, "I feel like we're really helping people. I had no idea all of our patients were so anxious and depressed." And so really felt like this was a great way to help people. And also by doing this mailing model, wasn't seeing the rejections, just the ones who were interested. We also expanded our educational programming to include more work with our internal medicine residents on really building those skills of communication. I mean, with or without a decision aid, you need to help people with a shared decision-making process. So how do you do it? Someone earlier mentioned about how do we initiate discussions about starting a medicine for a chronic condition. That's actually been a big focus of our program with our residents, using even decision aids to be used in the consultation. And we've continued our outreach to our primary care physicians in our practices who have long been so supportive of our work. So that's our story, and I guess we're ready for questions.
Well, I want to give a big thanks to everybody for trying this new storytelling approach, and I think it's apparent from this the extent of effort that has gone into the implementations in these organizations. So I think if we can see that without fully aligned incentives, we might be able to imagine what we could do when they are aligned. So with that, I'll ask for any general comments or questions. You can direct them to anybody in particular or just as a general comment. We'll start here, please.
Sure. Hi, my name's Janini Lugo. I actually work for the Center for Medicare and Medicaid Services. and we are about to embark on a patient and family engagement campaign that will actually have small tests of change in 25 states. And we're really excited to be here to hear a lot of what the pioneers are doing. We're behind you guys in kind of developing and implementing this, but this is good because these projects will be used to spread nationwide after we test and see some of the models and get some data results. So I'm really excited to be here and hear what everybody is doing. But I do have some questions about overcoming barriers, because a lot of what you're talking about is in like the hospital setting. And Grace talked about, how you overcame that, money obstacle. Money and time is a driver, but it's not the only driver, and it's not the only barrier. And sometimes I think that when it's overutilized, it can become a disincentive if that, stops. So I'm just interested from any of you, any thoughts or kind of like light bulbs that went off about things that kind of got you over a hurdle or a barrier that you were seeing, that you were bumping up against, that maybe we could use something definitely that's spreadable, but something that maybe we could implement on a nationwide scale to make sure that it goes a little bit further than where it is right now.
Anybody want to start? So maybe we'll just focus in on barriers regarding provider engagement as a particularly thorny issue. Would
sure,
that be
and not just the barrier, but how you overcame the barrier, because
right.
I think I know what the primary barriers are. I'm looking for ways to overcome
right.
them.
Well, I'll make sure. So I'll echo something that Lee said towards the end, which is that, there's this sense that I'm already doing this, and it's coupled with this sense that I already know all this information. But reality is you don't know all the information necessarily, and you're not really already doing this. And watching the decision aid, seeing the materials, becoming familiar with it, kind of brings people around to this is a thing I need to do more of, and really helps kind of align the work, because you start to see the deficit that you need to correct. And I think in our discussions amongst ourselves previously, I think everybody's been pretty consistent that if you can get somebody to watch it or get somebody to review the materials, all of a sudden they're a lot quicker to get on board.
Thank you. So actually, the materials are helpful, and it recognizes that this is information that doesn't have to happen in the visit, so it can decompress the visit and save you time rather than take time in the visit, as the preliminary information that Jack Fowler shared this morning then allows the visit to be more rewarding. So sharing the decision aid and feedback around provider reaction to patients who have watched decision aids may be helpful.
Just
Neil,
one more comment, and I'll start by saying this is not something we've accomplished yet, but based on the experience that I just had, the personal experience, I think the difference between what I observed the surgeon to do and what I believe shared decision-making is about is he did a very nice job of presenting information. He did not do a good job of understanding what my wife's goals were, why she was thinking about the surgery, what she was not able to do currently, and what she expected she would get from the surgery. That would have given them an opportunity to have a dialogue, not about what am I going to do, but what are you trying to achieve, and is this the right way to help you achieve it? The step that I'm thinking about taking is to try to frame just a couple of key questions that providers can use in the encounter that will get more at the preference issue. I think the point was made that we often do a bad job of diagnosing preference, and I think that's the place where we might put some energy into improving things.
Go ahead, Charlie, and then we'll have to move on, I think.
I would echo that in terms of the perception we've talked about of physicians thinking, I already do this. And when they're thinking they already do this, they are probably, relaying the facts well, but not doing that important piece of the preference, distinguishing the values and the preferences and actively engaging the patient in that discussion.
Thank you. A great question, and I'm just going to have to pipe in and take the facilitator's prerogative here to say that there's an opportunity to introduce shared decision-making without decision aids. And that is, if we even get that half of the equation, where we get providers in the habit of asking about what's important to you when you make a decision, even if we don't have the other half down, that's a huge step in changing the nature of the interaction. Go to this side, please.
Thank you. My name is Emerson Carvalho. I work with Janine with the Centers for Medicare, Medicaid Services. First, thank you for having us here. This has been a great experience. I'm also a physician by training. I'm an internist in the area of geriatrics, and I have shared a lot of your experiences with patients. But I want to just make comments here very quickly about we also in the moment now to launch the QIO's Patient and Family Engagement Campaign. And as I listen to the panel here and also the previous speakers, makes us feel much more comfortable and actually makes me excited because we are in synchrony on what we are doing. And it was very nice listening to the success stories, the challenges, because as we put together this Patient and Family Engagement Campaign, we conduct an environmental scan throughout the country. That we interview all our QIOs, the Quality Improvement Organizations, so they make recommendations on what would be a great and effective, successful patient-family engagement campaign for the outpatient setting. I work with the Centers for Clinical Standards and Quality. CMMI has another patient engagement with inpatient. We work together a lot as collaborators, so I want to just take this opportunity to introduce myself for future connection. As we put together this patient and family engagement campaign, the QIOs were tasked to choose a topic. So they chose a topic and they chose a target population in their states. As Janine mentioned, we have 25 states. Most of your states will be participating. And one of you here, I'm not going to say who, is going to be actually part of this because they are going to contact your facility to be one of their target population. So somebody here expect that contact very shortly. And another thing is like I really like somebody here, I don't remember names, but talk about use of technology. This particular campaign has a lot of encouraging QIOs and to encourage providers to use technology and how to interact with their patients. They propose several different topics and approaches to do this, and one in particular is a lot of use of online resources, internet, and apps like iPhones, iPads, whatever, links, videos. So I hope I don't have a question, just a comment and an invitation. I really hope that the meeting organizers will share your emails, contact, because in the future I'd love to share what we learned and also obtain from you all your experiences. And because a major task for the QIOs is collaboration and work together with CMS stakeholders like all of you. So my name is Emerson Carvalho, and I'm looking forward to maybe talk to some of you all in the future.
Great.
Okay?
Well, thank you very much. We welcome the invitation, I'm sure. Yes.
Daniel Wolfson with the EBIM Foundation and Choosing Wisely, and I think this goes to Neil maybe. Choosing Wisely is about informed decisions about things that may not be beneficial. And it occurred to me that maybe some of your infrastructure that you now currently have, and you're talking about value, that you would infuse some of these conversations about actually tests and procedures that are wasteful and actually injure potentially patients and certainly also cost money, not just to the institution but to them. So I was thinking, are you thinking about Choosing Wisely and the potential of using some of your current infrastructure for shared decision-making to this being informed decision-making, but still some of the same dynamics? And I know Maine Quality Counts is one of our grantees that are working in Maine, and I think they're going to approach you about Choosing Wisely. So, and any others that are thinking about this. I know I've talked to people at Mass General about this as well. So I just wanted, this encouraged me when you were talking, Neil.
Well, and the answer is that yes, Quality Counts has made it very clear that they would be interested in working on Choosing Wisely. I like the campaign because I think there's the concern out there that shared decision making may be equated with rationing at some point, that's the dark side of some of the stuff we're talking about. We're making a real effort as a system to focus on end-of-life care and advanced care planning. A lot of risk there that the rationing word will be thrown at us. So I know enough about Choosing Wisely to know that we would really like to participate. The details of how have not yet been worked out, but I think it's a great opportunity.
Thank you. Neil, since there are a number of questions, I think maybe we'll hold that to that response and hope that we can figure out a way to get more care coordinators or care navigators in the system to take on these good projects. Next, please.
Hi, I'm Mary Ann Udow Phillips. I'm the director of the Center for Healthcare Research and Transformation at the University of Michigan, and we are helping the state of Michigan with the implementation of the multi-payer advanced practice, primary care practice demonstration project. We have 475 practices across the state that are patient-centered medical homes. You have each talked from your own perspectives and your own generally integrated healthcare systems, right? And we've got a much more diverse group of practices. I'm wondering if you have a thought, particularly from looking at it from a payer's perspective, about how to bring these ideas to scale, how to get more practices that could do what you've learned, or what is this entirely have to come from self-generated from a practice itself?
I'd like to start with that. So we know we're in this awkward period of time transitioning from fee-for-service to some sort of a risk contract, and whether you're an integrated delivery system or a private independent practice, it's still an awkward transition. And one of the things that has struck me about the current payment code system is that time-based reimbursement doesn't pay. And I think it's not even an issue of developing new codes. It's just about how we value existing codes. So I'll give you the example that I may not have this right, but I would love to bring it up and be corrected if I'm wrong. That if you build for a intermediate E&M code 99213 on a time basis, say it's 30 minutes, and you got to document that you spent 30 minutes talking about a medical problem, making a decision with the patient. If you did not a time-based code, but the other type of where you did some hard type of a problem-oriented code and you did history and a physical exam, you could do that in 20 minutes, especially with the help of new technology and templates from EHRs. So the minute that we get into time-based codes versus I'm doing something to you that probably doesn't even make any sense as to why I have to examine this particular body part to get reimbursed for that code, you're going to lose money in a fee-for-service world. So a simple thing might be to recorrect how we value the time we spend talking with patients rather than doing things to them, and it might be able to encourage us more broadly to do this. Carmen.
Yeah, I don't know if this is on. I think one of the issues we're going to face is competing measures and where this is going to hit in the priority scale. And I'm afraid that we're going to lose some of our gains because other things are rising to the top. So I think if you can incentivize as much as you can by making it a higher priority, I think you'll have success as well.
Thank you.
Hi. Al Abraham, Kaiser Permanente. Again, I want to thank the panel. This felt like a group therapy session. We're all I'm trying to push this at Kaiser, and it's great to hear about all the experiences. I have two very specific questions to Dr. Lin and Dr. Simmons. Dr. Lin, the group visits, do you use a DA, or is it just a conversation? And then for Dr. Simmons, I wanted to know, after you switched to the MA approach with the annual visit, do you have a follow-up with the doctor after that? So just workflow questions.
Sure. So we do have the DAs, the decision aids. They are being shown, so part of the group visit is everybody gets an individualized assessment, and so while others are getting the individualized assessment, while they're waiting for their turn, they view the decision aids during that time. So there's a good use of sort of what otherwise might be downtime. And then they are also given decision aids, and some of that is discussed in the group discussion, but they're also given decision aids specific to any conditions that they might have to take home and view.
When we switched to having these precede the annual visit, the patients got an order form 2 to 4 weeks before their annual visit. They would get their, depending on when they sent in an order, they would get it turned around to them very quickly. So the hope was they could watch it or review the booklet before the annual visit and close the loop at the time of the visit, if you follow me. So it preceded the scheduled visit.
Thank you, Lee. Good questions. Don.
Michael started the workshop this morning by saying we're trying to move from the exception to the rules. We're trying to get at least the delivery out, and I think the panel's done a great job of sharing their struggles and successes in doing that, and I'd summarize it by just saying make it easy, automatic, and early, make it understood, expected, and measured, and make it rewarding for the patient, the doctor, and the staff. I think we heard how important that is. Carmen then said that's just half the job, and that she talked about how you really need to get the importance of the patient's response back into the clinical decision making and how key that is. And they, in North Carolina, I think this is the right place, that you developed the videos showing what the patients thought of these. Was that in your place? I think so. Okay. And also you did the social marketing campaign that helped to demonstrate that. Have the rest of you done anything like that to show how important it is to get the response back into the clinician at the decision point?
Anybody?
So the video that I showed, the reason why we did that was to kind of help within the organization spread the concept and get the value for the patient's point of view out to people, but also to spread that out within the community. So we then took that video, it's a 10-minute long thing, and to our patient advisory council to try to get more buy-in there. As we went into the integration with health partners, we showed it to them as a tool. So we were trying to use this methodology to educate multiple audiences about how do we get everybody to understand that this is important. And I think the medical assistants, as they were working on the project of implementing the PSA testing, really, it helped them a lot to see that people thought this was valuable, because then, okay, now it's not just another thing I have to do. And then the patient's own experiences with it afterwards are feeding into that. I think that answers your question.
Thanks, Larry. In this making it automatic issue, the ease of doing that depends a lot on the topic, right? Because we're really trying to catch people at a point where they are about to make a decision or in a decision window. And sometimes that's predictable and other times it's not. And leveraging the technology and now next generation of mining information, rich information from electronic health records may be helpful, and leveraging the referral systems to do that, because presumably many people are referred from primary care to specialty care at a time when they're considering something, may help us in automating the identification process so we get higher reach of those who are actually in a decision window. Marcus, last question, I think, and then everybody will be around for the rest of the day and tomorrow, so we can continue this informally.
So it's my sense that just like with medications, that adherence to watching videos or adherence to using the decision aids is also an issue, and just getting it to the patient is only part of the work. I'm wondering whether any of you had any experience in measuring the degree to which the patients actually then, watch the whole video or read the whole decision aid, and to what extent you've tried to manage that in terms of improving the adoption rate, if you will.
Carmen?
Yeah, as part of our measurement, we did measure whether people used it, whether they remembered getting it, which dropped off about 10% or so, whether they had used it, and it depended on the topic, but it ranged, and Jack Fowler's often pointing out that there's some social desirability because the nurses are asking the questions, but from 50 to 70% of the people that once they finished the questions, they actually used it. Now, that's not generalizable across everybody because it's specific people that are finishing up with the questions, but we've tried to do that. And we've called some people afterwards where the rates weren't as high as well.
Yeah, and as part of our, Jack also showed self-reported viewing as returned by patient questionnaires, so we recognize that that's one segment, and then there's a group that never bothered to return the decision aids and the questionnaires. But even amongst those that did not return the questionnaires, then at Dartmouth we did a follow-up phone survey of did you watch it, and I think it depended on specialty and topic. So in the back pain suite, where the decision aids were given after a visit with a clinician and probably endorsed, and the reason for watching it was explained, the reported level of viewing was somewhere between 50 and 70%, even of those who did not return decision aids. Whereas I think in Charlie, do you remember the figures on the? I think we also did on PSA, automated delivery or another screening test, and it was lower in any event. So under 30, yeah. So much is dependent on the endorsement at the time of the handoff, and simple things, scripting that in a way can have a profound impact if you explain what's in it for the patient to do that, just like prescribing a medication. They have to understand that.
So communicating about the communication is actually important.
Yeah. Thank you all. Well, I want to thank the panel and thank you all for your active participation.